All right. Well, good evening, everyone, and welcome. We are just a couple minutes past the bottom of the hour here, so thanks everybody for your patience as we've just been getting set up. We would officially like to welcome you to our VCSQI Summer 2026 quarterly meeting. Thanks all for being here with us tonight. I know this isn't everybody's first Zoom rodeo, but always want to give a quick reminder about the Zoom etiquette that we ask our participants to please adhere to. These are open meetings, so if you all can just keep yourselves muted while our presenters are speaking, but we will have open Q&A during any and all of the presentation segments. You can also use the chat feature or raise your hand to ask questions. And Sherry has so kindly put her cell phone, but we'll be monitoring the chat as well if there are any issues that arise. We have a fantastic agenda this evening, going over some data and a couple keynote presentations from two of our VCSQI members that we are highlighting tonight. One from Dr. Puisios at UVA and another from Cindy Cole and Cheryl Elkins at Sentara Lynchburg. I am now going to turn it over to our co-pilot for the evening, Ms. Sherry White, who is going to overview the CME aspect for tonight's program.
Good evening, everyone. Thank you for joining us as always. So, of course, as you know, we do offer CME credits for physicians, nurses, and physician assistants. We also do offer maintenance of care as well. And so this is just an overview of our objectives for this course to satisfy the ACGME guidelines. And so we are presenting you with an overview of what you expect to receive from this presentation this evening. Next slide, please. All right, and this is just our accreditation and designation statement. So up to 2 CME hours will be offered for our physicians, nurses, and physician assistants, also including the maintenance of care certification. So this is just a testament to what you can look forward to achieving or receiving this evening. Okay, and for our presenters, there are no presenters who had any financial disclosures to present. And so we're not having any advertisement from pharmaceutical or corporate organizations. So just look forward to some great content this evening. So you may be wondering, how do you claim credit? All right, so are the instructions. For those of you who have registered or email addresses that I have, I will send this information to you in our recap. But if you just simply go to cmevillage.com, or you can scan the QR code here, it's going to ask you to sign in, and we encourage you to use the same email address or username when you sign in, because typically if you use one Gmail, like use a Gmail and then your work, they do not sync. So use the same email address when you're claiming credits, and then just follow the instructions. Go to My CE and claim your credit, and you enter this wonderful code there, 3196, and this course will pop up for you. You just complete a short evaluation and you hit submit, and your credits are claimed. You can also visit the site to claim your transcript at any time. And if you run into any issues, feel free to reach out to the UVA CME office, who we are partnering with in this effort. The email address is listed there, or you can feel free to contact me as well. You have up until 7 days from today to claim your credits. And again, if you have any obstacles, please do not hesitate to reach out. Okay, so
Fantastic.
yes, thank you, Addie. I'm tossing it back to you, partner.
Thank you so much, Sherry. So, Dr. Lancey, we just got a message from him that he had an emergency case that pulled him away. So, we are going to provide the welcome and highlights from the board in his stead.
Okay, now back to my fearless leader, Eddie Fonner.
Thank you so much, Sherry, and very scientific on the data points there. She's designed a great scorecard that really tracks each of the individual tasks we're working on. For our next segment, we are going to go into our quality and outcomes measure review. And so this will be a quick look at our VCSQI databases. The 4 registries we're tracking right now are CathPCI, the combined STEMI registry, which includes chest pain MI and AHA Get With The Guidelines, the STS Adult Cardiac Surgery Database, and the STS ACC TVT database. This chart shows the quarterly volume here, which for each database remains relatively consistent. We might see an overall bit of an upward trend in the TAVR cases. If we had a little bit more zoomed in scale here, we might see that more acutely. There's also seemed like there's been a little bit of a jump in some of the STEMI episodes, so something we might want to look into as well in terms of year-over-year trends. Well, it's just a snapshot in terms of the number of cases we're looking at. So every quarter, in the neighborhood of about 7,000 to 8,000 patients go in our database. These are our measure specifications, where on these charts we're going to compare a rolling 4-quarter segment for each hospital against one another. So in this case, it'll specifically be calendar year 24 against calendar year 25. That's our latest data that we have. We utilize standard ACC and STS metric definitions. We group programs by volume where applicable, and then sort by performance within each grouping. So you'll always see left to right. If you're on the left side of the graph or left side of the group, that's generally where you want to be. And we do have on some charts tests that compare hospital rates against the rest of VCSQI combined. We're going to look at the cath-PCI data first up. This is a selection of the charts from our latest quarterly reports. You all can access these on our website, or let us know if you would like to take a look at these, and we'll send them over. The first chart we're going to look at is radial access site by hospital. This is, again, a de-identified look at our member centers down here on the bottom. This compares against VCSQI and ACC benchmarks. So VCSQI were about 70% radial versus the ACC is closer to 60. But within each volume grouping and between the hospitals, you see there is still quite a lot of variation. Top performers in the 80 to 90% radial, and then on the other end of the spectrum, we're still in the 40 to 50% neighborhood. Same-day discharge has been a measure we've tracked very closely here over the last few years. This is looking at elective PCIs only, excluding deceased transfer and against medical advice. Those patients that were discharged on the same day as the procedure, actually same day as admission as well. Pretty similar look here to the radial access, maybe even a little bit more variation between centers. So something we're working to standardize, especially as this elective population is moving more and more toward the ambulatory setting, like Sherry intonated a few minutes ago. Here is one of the measures we've looked at, again, very closely over the years here. This is stage 1 acute kidney injury. We have developed a set of guidelines from pre-cath all the way to patients who go on to have surgery. So if you are interested in looking at our AKI guidelines, please let us know and we'll share those with you, or you can also access those on the website as well. This shows that our VCSQI AKI rates are a little bit higher than the national average here, 9 versus 7.5, 8%. Again, a lot of variation between our centers as well. There are some programs that are achieving a statistically significant better practice than the rest of the group. That's indicated by these plus signs down at the bottom. I'll pause here. I'm noticing some people looking at the graphs here, so I'll take a minute. Let me know if you have any questions or comments as well. And this way we'll segue to our next database, but we're still on CAP-PCI. We're looking at the median door to balloon time for our STEMI population. So across all of our VCSQI centers, it's approximately 59 minutes, depending on geography and on center-specific variation. Some are down in the 40 to 50-minute range. Others are maybe 70 or 75. And this transitions to our look specifically at the STEMI database. So in these cases, we are able to drill into the STEMI records a lot more deeply than CAP-PCI, which is why we spent a lot of efforts in getting this combined STEMI database working between the Get With The Guidelines and chest pain MI registries. So the corollary for your last slide, which is door to balloon, this is our first medical contact to balloon. So when either the patient is first seen in the field to the time of first device activation. So you noted we were about 59 or 60 minutes on the last slide. The overall median for our STEMIs is only 73 minutes. So we're only about 14 minutes longer when we are looking at that entire time from first medical contact to device activation. Dr. O'Brien or Dr. Contos, as our chairs of VHAC, do you have any comments on this slide?
Yeah, I think, when we started 15, 16 years ago, it was in the mid 90s. So this represents, progress, albeit slow progress over the ensuing years, but definitely progress. Midway through our existence, about 10 years ago, we launched something called the Drive to 75, which is to get this number down below 75 minutes. Eddie, I think we've been as low as what, 69, 71, somewhere in that neighborhood.
Yep.
Now, I would say that this is good performance. It's probably a little bit of selection bias because we're selecting out centers that are fully engaged, that are participating with VHAC, VCSQI, things like that. So that's something to keep in mind. But also the other part of that is we're trying to recruit the additional PCI centers. So we currently have, I believe, 28 centers on, and I think we estimate there are probably about somewhere between 40 and 45 PCI centers in the state of Virginia. So if you're at a center that's not participating with this, or if you know centers in your region, please help encourage them. Eddie and I are happy to speak to them directly. We want to eventually, this has steadily grown, and I think we'll get there, but we want to get all PCI centers on this registry and continue to make improvements.
Thanks so much, Dr. O'Brien. We have a couple more looks at our STEMI data here. So this is our first medical contact to device less than or equal to 90 minutes. So percentage of cases that are seen within 90 minutes. We're at about 86.7%. I think this is down a little bit. We were closer to 90 previously, but it still goes to show that wide majority of patients are being seen in that 90-minute window. We also track such things as transfer times. So this shows how widely varied of a state Virginia is, where transfer times for some of the centers, perhaps in urban areas or areas where hospitals are closer together, can be less than 10 minutes in terms of the median transfer time, 10, 15, 20 minutes. But you look on the right side of this chart, and transfer times are closer to an hour. It just shows how big our Commonwealth truly is. This isn't meant to shame anybody. I mean, it is what it is when it comes to ambulance and air transfers, but we are tracking this in our STEMI registry as well. And I would say it's instead of benchmarking against your peers here, it's interesting to see, has your blue bar gone down, or are you improving against your historical performance? And if so, then that's probably a more apt comparison here. We are also tracking measures like this within our VHAC work groups. This is what we call direct to cath lab. So it is when a patient is admitted, and the first evaluation location is either directly in the cath lab, or they have an ED stay of less than or equal to 5 minutes, what we call a ED fast track type of case. So we're looking to encourage this more so. We've taken some steps to standardize this patient population. Now we're looking at those who are presenting by ambulance only. We're excluding transfers, arrival by air and personal vehicle. We've also done a little bit more work to drill into the pre-act population, which data looks pretty similar here. Overall, though, we're less than 10% among this patient population who are getting fast-tracked or bypassing the ED. So looking to definitely improve on these rates with our VHAC work groups going forward. Okay, and the last database we're going to look at tonight is going to be our transcatheter valve therapies data. We looked at the STS-Q4 data last time around for the adult cardiac surgery, so we're not going to specifically look at those tonight since we don't have any new data to present in the adult cardiac world, but we will look at our TVT data. So looking at TAVR, I wanted to start out with what I thought was an interesting view, where we're looking at the STS predicted risk of mortality for our TAVR cases over the last 2 years here. The overall average predicted risk, or PROM as it's called, is almost 5% in the TAVR population. And when we look at the STS adult cardiac population, for isolated SAVR, the average predicted risk was only 2%. So I thought that was an interesting difference, where overall, we're seeing more TAVRs being done, and they are significantly higher risk here than our surgical cases. This chart shows a breakdown of the device types that are used. So mostly Sapiens. Second most prevalent is Evolut valves, and then there are a handful of Navitors being used. I wanted to share our stage 1 AKI for the TAVR population again. Something we didn't look at specifically with the AKI work group, but rates are pretty similar to what we saw over on the cath PCI side. So this could represent an opportunity to standardize some of the practices that were developed as part of the AKI guidelines here, especially maybe for the centers on the right side. And that is it in terms of a high-level view of our data. If you'd like more detailed views, if you'd like custom analyses performed, we're always happy to look at those with you. We can literally look at any cross-section of any of the hundreds of fields that are in our 4 registries here. As Dr. Bryan was mentioning, there's cost analysis that is ongoing as well. That will be a bigger part of our reports going forward. But we always love to work on data and work on analytics with you all as part of our drive toward improving patient care. So please let us know how we can put this data to good use. Thank you all. Any comments, questions, suggestions for the data?
Thanks, Eddie.
Well, Judy, since we've got you, I believe we are going to call on you to introduce our next speaker. So Judy, please take it away. Oh, you're on mute though.
All right. I am so excited to be able to introduce Dr. Pusios. He is a clinical professor of cardiac surgery at UVA and works at Riverside, whom we have a joint agreement, a practice agreement with. And he's amazing. He has really basically international experience. He studied in Greece and he practiced in the United Kingdom, and including the Onassis Cardiac Center and the University Hospital in Southampton. And his practice is really expert in mitral valve repair, minimally invasive mitral surgery, coronary artery bypass, valve repair, valve replacement, and structural heart procedures. And before coming here, he was in the Liverpool Heart and Chest Hospital and the University Hospital of Southampton, which, of course, in England, in socialized medicine. So he could tell you how much everything costs. And he also had multiple leadership roles in his surgical training and where he worked. And I will tell you, he is also capable of doing an amazing control chart. And I may have had time to go through the STS report for everybody who publicly reported and did a beautiful standard error and gives a great kind of vision of the STS because the volumes are actually publicly reported too. So data is his thing, and using data to improve patient care. And I'm super excited to be able to have him speak tonight and to hear what he's going to say about the postoperative AFib prevention strategy. So Dr. Pusios, you take it away.
Thank you so much, Judy. I'm really blushing on your good words, and I'm absolutely excited for the opportunity, and I'm very grateful for the opportunity to speak to you guys today and effectively present our experience from the application of a pharmacosurgical protocol for post-CABG atrial fibrillation prevention at Riverside. For whoever was at I think one by the last of the research and writing committee meetings, there was quite a bit of a nice discussion about the postoperative post-CABG AF occurrence. That's a problem we all know exists, and we're all looking for measures and ways to reduce it. And effectively, what we're wanted to present is a quality improvement initiative, or if you would like, our story of going from 43% to 23% in a period of a few months applying this protocol. And what I would like to cover is obviously why it matters. I think pretty much everyone knows that. We'll just give you a couple of numbers to as a sort of a preliminary work. The application of the protocol we're using is the Mass General PAPA protocol. Believe it or not, the first time I read it, I thought that's probably a funny name, but actually that's the name of the protocol. And to mention that, we had the Papa Bear old protocol, so that makes it a full circle. What exactly was our initiative to improve quality regarding postoperative AFib in Riverside, and more about the results, baseline versus the operative data, primary and secondary outcomes, and then some conclusions and lessons learned from the real world application. So let's see if that works. Okay, it takes a bit of time. Apologies for the click to transfer the next slide. So we do know that postoperative AFib is around 20 to 30% of cases. It almost doubles the perioperative mortality risk, more than doubles the risk for stroke. And according to as per our data, we need 5.3 patients to treat to avoid one AFib. The clinical consequences, apart from the major heart markers that I've said already, is prolonged ICU stay, prolonged hospital stay, increased anticoagulation burden, which is a financial burden, as well as a risk of consequences of anticoagulation to the patients after the operation. Plus, it increases the risk of late AFib recurrence. And to a certain extent, there are discussions about higher dementia and heart failure risk, but certainly staying on AF is not a good thing to do. It's quite interesting that our effort started before the new STS guidelines came to be announced, first in the STS meeting in January, and then, excuse me, in paper in April 26. So how it started was Rob Strange, my colleague here, thoracic surgeon, that came up with the idea of the excuse me again, of the Mass General Protocol application in a real-world regional hospital. We were not aware that the guidelines were to come at that stage, so we were very excited that our timing and the guidelines happened to be the same thing. The highlights of the guidelines effectively, and I'll give you a bit more in the next slide, but the class 1 indication includes perioperative amiodarone, which is indicated, so it's a class 1 to prevent postoperative AFib, and the class 2A indication is posterior pericardiotomy should be considered at the time of the surgery. A bit more analytical, that's pretty much, if I can say, the take-home brief or business summary of the guidelines. Class 1 is perioperative oral amiodarone as a preventive measure. Obviously, if we have hemodynamically unstable postoperative AF, electrocardioversion as soon as possible is indicated, as long as we are sure that there is no clots in the left atrium. And obviously, beta blockers, which pretty much everyone's using perioperatively, it's a reasonable 2A class indication. And the pericardiotomy now has been included as 2A class indication at the time of the surgery. 2B, there's more than the colchicine, magnesium, glucocorticoids that have been discussed, used over many years. I have quite a few colleagues in Greece that quite a few of them made their PhDs based on different things that they were giving to try to treat AF, and I can tell you they're all published, but nothing really worked in the long term. And obviously, it's class 3 now. It's pretty much preventative to routinely replace the potassium to prevent AF. In actual fact, it has been found in a few studies that it increases the chances of having AF, most likely because it messes with the repolarization of the membrane. So what's the protocol we tried to imitate or try to apply from an academic center to a regional center is published by the Makarem and colleagues in Annals of Thoracic Surgery in 2025. It's the PAPA protocol. And effectively, it has a posterior pericardiotomy and prophylactic amiodarone. So for the posterior pericardiotomy, it's a very simple technique, effectively a 4 to 5 centimeters, a couple of inches, vertical incision, posterior to the phrenic nerve, effectively from the left inferior pulmonary vein to the diaphragm. So it's not an exact science. Of course, you have to be very careful not to injure the phrenic nerve because that's going to be really not a good side effect or consequence. But it's technically very easy to do. Again, there are potential timings, and that's according to surgeon preference. I prefer to do it once I finish my last bottom end. We lift the heart very easily. We can identify what the phrenic nerve is and perform it then. The idea of the mechanism, according to the protocol, and based on the PALAX trial that showed very good result, and also the meta-analysis of 25 previous randomized studies, it reduces almost to half the risk of postoperative AF through pericardial drainage into the left pleural space and reduces the dreadful 1 centimeter of posterior effusion that most people have after surgery. We scan everyone, and theoretically that stops irritation of the left atrial floor and ergo causing AF. On the other hand, the pharmacological part of the protocol is IV loading of amiodarone at 1 milligram a minute over the first 10 hours. So effectively, you just give 600 milligrams gradually in the ICU while the patient arrives there through the central line. And from there on, oral amiodarone at 400 milligrams BD over the first to fourth postoperative day. And the evidence was based on clearly now on the STS guidelines and also the Papa Bear study that I measured that showed significant reduction of postoperative AF, almost half of it based on use of amiodarone. So the results of the study that was applied in Mass General showed a reduction from 32% almost to 18%, which is quite strongly statistically significant, and that's how it was published, and that's what it gives us the incentive and the motivation to try to see it in our world. So in our design, we had a bit of discussion, who should we include, who should not we include. So effectively, we just decided to include pretty much everyone, as you're going to see. So the pre-protocol group is the whole of 2025 in Riverside. There were 94 isolated CABG patients. They had no percardiotomy and no amiodarone prophylaxis. So we adopted the protocol on January 2026 after our discussions before I arrived here in December. And the group that I'm presenting and we analyzed is 42 patients between January and pretty much 20th of May, when I had to finish up the analysis to complete the presentation for VCSQI, because we were quite excited by the findings. I will let you know at the end where we are actually now in the beginning of June. So that included the full protocol, ideally with a posterior pericardiotomy and prophylactic amiodarone. We included everything as far as cabbages were concerned, apart from emergency cases or permanent AF. We exclude emergency surgery and if you were on amiodarone before. We discussed a bit about whether we should include paroxysmal AF or exclude them. And although we were thinking, let's exclude them and make it more, safe that we will have a good result, we decided to use pretty much everyone. So these are all consecutive cases. Nobody has been left behind apart from the emergency surgery in the permanent AF patients. Now, between the two groups, although they're not randomized, they're just basically calendar years compared to each other, the actual parameters are not really statistically significant, so they're quite well-matched groups. If any, I would say there were slightly more moderate to poor LV function patients on the post-protocol introduction. Creatinine is a little bit worse. So in all aspects, if anything, the new group or the post-introduction of the protocol group is slightly worse background patients compared to the pre-operative. So we were very careful to check that so we don't really sort of make a nice result by including nice patients. The operative variables, not really dramatic difference, pretty much statistically non-significant difference between bypass time. There is a difference statistically on the cross-clamp time, and I probably have to blame myself on that because I do on-pump surgery, but I do the top ends on the clamp. That reduces the bypass time, but increases inevitably the cross-clamp time, and slightly different on the number of grafts. But again, that's a random finding. I'm sure that's can be probably comparable once we are getting enough numbers. But still, that tells you that we are not really choosing simpler or smaller operations to compare after the introduction of the protocol. Obviously, there's difference. Before there was no application of the protocol, and now we have 88% of people had posterior pericardiotomy, 85% of people had adoption of the amiodarone, and the full protocol with both components, 78% of patients. And I'll keep that number to discuss about it in the later slide because it has importance. So what are the outcomes? I tried to make it too obvious there. So the pre-protocol, the whole 2025 year, we had 42.6% of patients with postoperative AF. I didn't include intentionally the slide from VCSQI with it's around 25, 26%. I think in par with the STS data. The names of the hospitals I understand are not included. We have all codes, but pretty much I think everyone knows who everyone else is or might be guessing. From 42.6%, we went down to 23.8% at the mid-May, basically 10 out of 42 patients versus 40 out of 94. That represents pretty much a 45% relative risk reduction, and indeed, we achieved the 5.3 patients needed to treat in order to have a difference of one patient with AF. If you really go statistically, because it has a chi-square which is statistically significant, the Fisher exact test, because it's a small number study, is marginally so. But the bottom line is that this is quite an obvious to the naked eye difference between the two groups and the two results. Now, secondary outcomes. Not dramatic difference apart from the discharge on the anticoagulation, which is statistically significantly better. So only 12% of our patients have been discharged on anticoagulation, because clearly we had 23.8% of AF and half of them converted to sinus rhythm and they did not have to be discharged on anticoagulation. That's a significantly reduced number, which includes less costs and less chances of a patient having to suffer any consequence from anticoagulation. Mortality, stroke, reoperation for bleeding, obviously intubation, pericardial effusion, no differences. The length of stay in the ICU, although it's not statistically significant, it has been reduced, and the same applies for the median stay in the hospital. And I'm not sure whether I have to say that AF treatment and reduction has a point on the reduction of ventilation hours, but that's quite also a number. It's not statistically significant, but still impressive to see. So the key outcomes, as I mentioned, from 43%, we went down to 23.8%. The numbers to treat exactly one case of AF prevented per 5 or 6 operations. Statistically significant discharge, number of patients on anticoagulation, and the length of the stay in the ICU reduced, which I think has to do with AF as well, because at least at Riverside, we keep people inside the ICU when they have atrial fibrillation. If we compare our results, even our smaller number results, to the literature, the PAPA trial started from 32%, so they started from a more advantageous position, and they went down to 18%. Statistically significant, they were matched pairs, propensity, retrospective study, of course, but propensity matched. The original pericardiotomy study went from 33 to 17. That's an impressive difference. I'll keep it a little bit with a pinch of salt there. And the meta-analysis exactly shows probably a very ideal world of 23% starting going down to 11%. Again, I would keep the numbers a little bit, as I said, because I'll break down a little bit the subgroups later on, and I'll tell you where we are now as well. But that shows that we are not very far away of the drop, at least, on relative risk or actually absolute risk compared to the published data from all these big center studies. So beyond AF, from what we are doing, as you can see, we're doing a good job, generally speaking. So we have no deaths over almost a period of a year plus. We have only one death across 200 patients plus. And we are reducing the ICU stay quite considerably. So, and we're quite happy that this is applied with the affiliation of UVA and Riverside Regional. Now, in terms of fidelity of how the protocol was adhered to, that was the early days, and I think we should be happy that we were that good, about 85% on definitely on posterior pericardiotomy being performed and keeping the amiodarone prophylaxis, and 78% of both of them, as I said. Now, if we break down to the 33 out of the 42 patients that had the full protocol applied, the AF there was 21%, versus if we don't do the whole thing, it's 33%. So, simple terms, you have to do both of them to have the maximum benefit. And that's quite important because then you see the numbers going to the low 20s or even to the teens, which are on par with the randomized studies and the RCT meta-analysis. Reason for exclusion, some confusion with paroxysmal AF. In 2 cases, anatomical surgeon discretion. One might say that a surgeon, might be me, I forgot to do it, which is not happening again, but that's real world, and we have to, disclose everything on that one. So from what we learned from the lessons, it worked very well. It was a very, very efficient, very quick departmental consensus. We went through the quality meeting with our audit department who supports it, and actually they are doing a great job. And I think Chelsea Lovelace is here today and listening, and they're basically central to data capture and keeping an eye. And we had discussed that if we see any different, any bad results or whatsoever, we should stop immediately and reassess. We believe that was a strength of the study that we adopted fully the protocol. We didn't try to change it. We just made it work. And also the fact that we entered an amiodarone order set in the ICU to help the ICU to apply that, seamlessly. And again, that was the challenges part that we had to learn, to remember to do it on the appropriate timing, that the nursing staff in the ICU knew that they have to look for the protocol. Now they're asking for it right away proactively, so that's good. They know it's used. And also some data collection that we have ironed after the first couple of months. The improvements were basically a pre-printed amiodarone set at consent, which helped immensely to apply that as a normal protocol. Obviously, we have check of the QTC and ECG reasons to avoid using amiodarone if necessary. And from there on, that we're keeping on a good close eye, and everybody was very excited to see month by month how the results were dropping into the percentage to reach where we headed. Now, obviously, the study limitations, it's a small number, not a randomized trial. I think that goes in all pretty much studies apart from the randomized studies. It's a small cohort. However, we found that these are results that are so impressive that we wanted to analyze them and see them earlier rather than later because they're so good. Now, if you remember what I said is that was at 20th of May. So the actual number on the 5th of June, tomorrow, it would be 10 out of 45 patients. So another three bypass patients have been discharged without IEF, and one is at the moment in-house. So we'll wait to see if we're going to go 10 to 46. So that alone tells us that we are now below the 22% mark. And if we count again the full protocol, the both arms being used, we're getting into pretty much reaching what the randomized studies of an academic center have shown that it's feasible, which is significantly less than the 26%, which is average, I think, of VCSQI and in the STS national data. Obviously, this is a single center, and pretty much what I'm saying is we have to make sure that we are fully adherent to applying the full protocol. And obviously, as all studies, it's good to have really validity of the data and completeness of the data to be sure what we are doing. I think I got another slide. Yeah, that's it. So if I have to say about, take-home messages, applying the protocol reduced our AF dramatically. I am allowed, I think, to say that from 43% to 23% in mid-May, 21.9, I think now. So that's pretty much a 50% relative risk reduction. And that's how we think is clinically meaningful. And actually, it's going now part to part with published literature. We have a significant reduction in the anticoagulation at discharge, which I think is more important because most patients, they don't really know what AFib might be, but they definitely know that they are on Eliquis or they have to be careful not to fall down and have bleeding or any other risks that goes with Eliquis or any other anticoagulation form. They're both of the arms of the protocol and of our study or our application have now been fully included in the guidelines that are out on the 25th of April, I'm not wrong, published on from the STS. So I think we're exactly perfect on the timing, and this is a real-world validation beyond an academic center like MGH or the other sort of centers where the data has been based. We believe the protocol is very easy to apply, as long as you remember, and I'm beating myself on that to do that before you close the chest. And we believe that post-operative AF, it's not a God-given 26% no matter what measure and metric. We think that it's definitely easier to take it below the 20% and in ideal world even reach the low teens. And all it needs is systematic implementation, and to be accounted for, you need good audit data as usual. And we hope that that helps, might be a bit of a statement, to open up the discussion for such a simple quality improvement measure across the, whoever wants to do it really, Virginia or elsewhere. So I think having said that, and if my slide moves at some point, yep, I would like to thank you both for the opportunity to talk about and the ability to show what we've achieved in a very short period of time using an academic affiliation into a regional center. And thank you for your attention.
Thank you, Dr. Buzios. We'll open the floor for a moment. If anyone has any questions, feel free to come off of mute and let's pick this wonderful brain if we could.
Mm-hmm. Dr. Pusios,
Hi.
this is Judy. Oh, I'm sorry, you go ahead.
Oh, no, please go ahead.
When we've tried loading the amio in the ICU, and that was a full load. Now we did the 150 bolus up front, and it doesn't look like you had this. What happened when your patient was hypertensive? Did you lower the rate or hold it or go up on pressors to accommodate a low map. That was a huge issue for us. We had a hard time getting it in.
I think we would treat those both separately. We could keep the amiodarone going and we would use vasopressors because I think that's not connected to each other with a little bit of most patients would need, at least I grew up in a place where we were not particularly bothered by using a bit of vasoconstriction as the patient were warming up. So we would keep both the protocol to stop the AF because if the patient goes into AF, he's going to get worse as far as the pressure is going to go. So I would be keen to keep the amiodarone going, and we're applying that, and vasopressors needed, if needed, to use them freely.
Did you have a lot of nausea or anybody who quit the amio because of nausea?
Not at all from these patients.
Okay. Thank you.
Derek, you had a question? Oh.
Yeah, I was wondering, so you create this communication between the pericardial space and the pleural space. What do you propose is the mechanism of how that is helping reduce the incidence of AFib?
I think based on what the literature suggested, basically the protocol created is absence of the posterior pericardial effusion. I mean, most of the people, I mean, here we don't do that often, echoes postoperatively on bypass surgery. In my center, we were doing it on day 4 on pretty much everyone, and you saw always, and I'm sure that everybody knows this 12 millimeter posterior, limited posterior fusion behind the left atrium. I think that's what creates the irritation. Most of the patients that we have done scans now, they have no pericardial fusion. You can see nothing behind. And I think that's the biggest mechanism. I think the amiodarone helps, and as the evidence shows, you have to do both. But my feeling is that this little incision is actually the key.
Thank you.
Dr. Spear?
Thank you very much. Thank you very much for this. It's I think, an excellent overview, and we've been using the IV amiodarone which is approaching about 15 to 18 years now, and it really did drop it down between 11 and 15%. But I must say I have no experience with the posterior pericardiotomies, and I may have missed it, so forgive me. But what is the data for only using posterior pericardiotomy versus the combining it with amiodarone? Is there a role for that? And if there's a inability to give the amiodarone?
I think based on the PALAX study or the PALAX trial, I think I'm not sure I'm sharing the screen, but I think you see it, my last slide there. It's the Gaudino paper about the PALAX trial. That's pure pericardiotomy, and that was from 30 to 17% without necessarily adding amiodarone. So my gut feeling, my personal thought is that the pericardiotomy is the key, not the amiodarone. It's just that we wanted to apply the protocol from Mass General because we wanted to be able to do something based on hard evidence of a reasonable big study. I personally think that the pericardiotomy alone is quite significant part of the treatment.
Thank you again. Appreciate all your efforts.
It's a very, in our opinion, was that it sounds. I always had heard that in Europe, and it's so silly that so much small procedure, not really risky unless you cannot hit the phrenic. You have to where it is. It takes literally 5 seconds, and the difficulty, and that's why we missed a couple of the patients. We missed it is because we didn't do it on time, and then we're off bypass. The heart's beating, big ventricle. Do you really want to lift it up? You can, but we sort of didn't want to annoy the heart. I think what we established is the timing to do it is, for me at least, I do all the vein bottom ends, then I do the lima, then I do the pericardiotomy, and then I finish up with the top ends. At that point, the heart is, you can mobilize it. I do on pump, obviously, but I guess on off pump may be a bit more difficult, but I think the heart can tolerate, after the lima is on, can tolerate a bit of handling. And it's only 5 seconds to do a 2 inches cut with the diathermy.
Good. Thank you.
Miss Vicky, I see your hand. Feel free to come off mute.
Hello, I'm from a hospital in California, and we had the same experience. We had a wonderful amiodarone protocol, but our rate only went down couple percentage points, but once we started the posterior pericardiotomy, it was wonderful. We dropped down to 14%, but then we had a little uptick to 18%. So I'm going to take back that to leave patients on the amiodarone and utilize our pressors. Normally, if they have hypotension, we stop the amiodarone. And so thank you for that information.
I fully agree. I think the high teens is where pretty much most of the studies show that that's pretty much the real world, you know, where the ball stops effectively. But I wouldn't sacrifice the amiodarone with the blood pressure. I would just treat them both on separate paths and separate sort of issue.
Thank you.
Comment from Dr. Contos from VCU in the chat. To avoid hypotension, VCU has adopted a standard to infuse bolus over 30 minutes in less life-threatening arrhythmia. Do we have any additional questions for Dr. Pusios?
Can I ask one more? Did you have a lot of bradycardia? It's Vicky again from California. We sometimes get a lot of bradycardic patients.
I don't think we had. I think I have somewhere on the postoperative. I might not gone through that a lot, but on the secondary outcomes, what I say is I call it postoperative heart block, but that was bradycardic, significant bradycardic episode that didn't end up with pacemaker. It was 2.4%. So basically, one patient had a bit of slow heart rate. We just allowed him to recover.
And what did you do with the amiodarone for if patients developed bradycardia? Did you stop it?
I would personally not stop it unless it goes below 50 heart
Okay,
rate.
thank you.
Excellent. Thank you again, Dr. Pusios. And once you get the second half, feel free. You have an open invitation to come back and just share your work. It's been very fascinating. And we're just looking forward to seeing what more is to come.
Appreciate it.
Okay, everyone. So our next highlight of the evening, it is with great pleasure to introduce Cindy Cole and Cheryl Elkins from Central Lynchburg. Cindy is the Senior Director of Quality and Clinical Care at Central Heart and Vascular Institute, with a strong background in cardiovascular services, quality improvement, care coordination, and regional initiatives through VHAC and VCSQI. Now, Cheryl is Centra's cardiac surgery nurse navigator and has been with Centra Health for over 8 years. She has experience in cardiac critical care and OR prep. And so if you could recall at a prior quarterly meeting, I want to say December, this team had introduced a project that they were working on as it relates to patient education around heart surgery and navigation. And so we invited them back just to share their practice. And so it is with great pleasure to introduce Cindy and Cheryl. Please take it away, ladies.
Good evening. Just want to thank everybody for giving us the opportunity to present here tonight. So prior to COVID pandemic, Central Cardiac Surgery offered in-person classes to all of our surgical patients to provide that pre-op and post-op education. The classes were received well, and the patients were appreciative of the attention and detail that was put into the classes. Of course, like everything else that resulted from the pandemic, the classes went away at that time, and we turned to an impromptu call to each patient to go over education and introduce those things to them. Now that things have settled in and we have started to build up more cases again, and our census is staying higher, it's become inefficient for our office to teach every patient via a phone call. So Cindy Cole was one of the initial people that brought about the classes previously, and she is my boss and has done a wonderful job with helping me get this class back off the ground again. We have put a lot of work into it and finally have them rolling seamlessly. It took some time. Can you advance to slide 2, please? As you can imagine, there's lots of pieces to the puzzle to getting these meetings up and running. The class kind of leads up to we do a pre-op day. That pre-op day we bring in our patients. They each start early in the morning. They come through all of their testing in one day. They have lunch there at the hospital, and then they move on from that into that class that we offer at the very end of the day to kind of bring all of that testing and all of that buildup of information into one room so that we can share that with everybody. Uh, the goal of that pre-op day definitely streamlines and makes us more efficient in our workflow. But the ultimate goal is to increase the teamwork between all of the multiple disciplines that bring that cardiac surgery in, and also to make a more positive experience for our families and our patients. Our patients, since our community is so spread out, a lot of our patients do spend up to 2 hours just driving into the hospital, and we try to prevent them from having to do that on multiple days, um, which definitely has been a plus we've found that out through the feedback that they've provided for us. Um, the good thing about this too is we're able to stress the education a little bit more, provide more time for questions, and it has had an impact on our readmissions. Slide 3. Um, there's many teams, as you all know, that go into a cardiac surgery. When we started this process, we involved radiology, respiratory care, volunteer services, of course, our cardiac surgery folks, um, dietary, everybody kind of come in together because in order to make a pre-op day successful, we had to come up with a schedule. That schedule needed to flow smoothly, and it needed to benefit each and every department, of course. But some of the things you see here on this slide, are the things that we discussed to make this schedule come into fruition. So we, let's see, slide 3, no, slide 4. During our meetings, we sit down and we talked about how to make this schedule make sense to everybody and benefit everybody and create a seamless flow for our folks. Um, we the pre-op team, which was somebody from each one of those disciplines, we got together about once a month and talked about how we were trying to gear things toward creating the schedule. So it wasn't something that happened overnight. We really had to work at it. And thanks to Cindy's lead, having experience in this before, she kind of kept us all on track and give us that overall view that we were all trying to accomplish. Once we got everybody together, kind of figured out what we were supposed to do, or what we were needing to do, we ended up making the schedule so that there was a couple of gaps, as you see on this slide here. We bring in people to our pre-surgery clinic. When you see that pre-op up there at the top of the schedule, that is the pre-op appointment from our pre-surgery center where they go to get their x-ray, they get their blood work and their urinalysis, and their little pre-surgery physical. So we have one patient come in at 7:30 in the morning, and then bring the next one in at 8:30, so that they don't cross over, but they can kind of start moving through that process and open up the different slots for the next person to come in. And then we bring 2 more patients in at the 10 a.m. mark that you see there on the right-hand side. Once these folks start this process, they just flow from one place to another. Our pre-op center is over at near our Virginia Baptist location. So they do have to leave that location to come over to Lynchburg General for the rest of that testing and for the class. Fortunately, we're not that far away from that location. So those folks will come over to Lynchburg General. They'll start out, the first person that had the 7:30 appointment will go into that vein mapping, and then the other one will go to different testing, and they'll kind of switch back and forth, waiting on those next folks to come over from Virginia Baptist and flow through the system. So once we get everybody to Lynchburg General, most of the time we have them through all of those appointments by about 12 o'clock. We provide them with gift certificates or for our cafeteria so that the patient and a companion, because we want the family to be involved. We want somebody else there. It's always better when the patient has a secondary person they can kind of bounce things back to once they leave. Once those folks get there, they come up and they have lunch. So they have a little bit of downtime before they go into the classroom. And we provide the lunch for them so that, they're not having to leave the hospital and then come back and fight to find parking and get frustrated. Um, we we try to make sure that everybody gets to the class on time. Usually, we start at 1:30. When we get everybody to the test to the classroom, we start out. There's only two people that presents the day of class. One is the dietitian. She usually takes the first 30 minutes of the class, goes over the cardiac diet. As you can imagine, lots of questions here. We talk about the sodium, and we talk about the cholesterol and those sorts of things. And she spends time with them there. The last hour is a presentation by me, or one of my associates, Karen Harvey or Hannah McFarland. We all go over the actual surgery part of the class. First of all, in this meeting, we make sure that everybody understands that we're not going to divulge any personal information about their particular case, but encourage them to share anything that they're comfortable sharing, and of course, remind all the other participants that whatever we do discuss in that class, that they leave it there and don't share it outside. So we start there, and I go over, the basic instructions for surgery. I go ahead and reiterate everything that they told them at the pre-surgery center about using their wipes and taking their shower the night before surgery, all of those things. We talk about we talk about actually what a cabbage is. Our books, we're very fortunate to have pre-op books and post-op books that I let guide my instruction through our meetings. Those books, we go through it front to back, provides a lot of great information. We talk about risk factors and, kind of what got them to where they are, because some of them are very shocked that they live a healthy lifestyle, but they still have cardiac disease. So we talk through some of that stuff. We talk about what a cabbage is, what veins and arteries we use to repair those blockages. We talk about valves and mechanical valves and biological valves. We talk about the left atrial appendage, and that, most of the time we put a clip on those, and why we do that, and, what it does. And then we move through, I got through a very detailed surgical day experience. I start out with when they arrive at the hospital. They're going to move from one section to another, like registration, into the cardiac pavilion, then to the prep room, and then to the OR, and then to the ICU. I go through that step by step, and I kind of give the family a timeline of what they can expect as far as communication from each and every person at the hospital. That they'll get that 8:15, 8:30 call from the OR saying we've gotten started. What that means, that's the first surgical incision. And then we go into, uh, the next time that they see me will be when the patient goes on bypass. And that means that we have actually started the actual heart part of the procedure. And that 2 to 3 hours later, they'll see me, and we'll go over the fact that will be when they've come off of bypass, and that they're now the major part of the surgery is over, and they, we'll move them upstairs to the critical care waiting room, and that's where the doctor will come out and talk to them after surgery, and then I make sure that they get back to see their person before they go home from the hospital for that day. But we talk through all those things to give the patient comfort, but also to give the family comfort that they know somebody's going to be there communicating with them and leading them through that process. Um, I allow lots of time for questions. Once we get through that surgical day, we'll actually go through the hospital stay, what to expect in the hospital, that we're going to get you up in the morning into a chair, physical therapy, occupational therapy is going to work with them each and every day. We're going to institute nutrition back the next day. They're going to walk the hall the next day. We talk about drain tubes and pacemakers and all those things that, so they're prepared for what to expect. Um, we move from that education on to what happens when they go up to the um, step down unit, what to expect there, their average stay in the hospital. And then we talk about discharge day, and that's when one of the clinical navigators, myself or one of the ladies that works with me, will go up and actually sit down and do their discharge education, provide them with that book about going home after their surgery that has all the details. But we don't just give them the book, we go through the book. We make sure that they're very clear in what their surgical expectations are, making sure they're following those sternal precautions and they're taking those vital signs after surgery, and so that we can stay on top of their medications and tweak anything that we need to. We make sure that they know what kind of infection signs they need to be looking at, anything that seems concerning. We send them home with a little red rubber bracelet that has our phone number on it, and we make it clear to them that we answer that phone 24 hours a day, 7 days a week, so that they know that we're there to be a resource for them following surgery, and that it's not so scary when you know somebody's there to answer those questions. Um, so we go through discharge. The day that they leave, we give them the books that have all their appointments already made for them. We give them a hygiene kit that has antimicrobial soap and wipes, in order for them to care for those incisions, and give them a little extra information to make sure that they know to take that shower every day and protect those incisions and look at them every day. So we send that stuff home with them. And when I do my classes, I reinforce, the showers. I reinforce taking time and doing their walks every day and taking the rest period after each walk, but making sure that they're getting that 30 minutes of activity every day. Um, we, sorry, I just lost my total train of thought. Just making sure that at the end of the class that we've been through the pre-op education, the time at the hospital, the discharge, and quite frequently they get into discussions among themselves. And we get a lot of questions out of that. So a lot of the questions that they would normally go home with, especially if they just took home that book, they, get engaged and they talk through things, and they kind of express the concerns that they go home with, and we know they do, but they don't like to share. Um, so can you advance slides, please? As I said before, this pre-op day could not take place without the collaboration of all of our units. And I do a survey at the end of this class, and we talk about what they liked about it and what they didn't like about it. I haven't heard much of things they didn't like. They do express appreciation for the time that somebody actually sits down with them and talks to them. I do a survey at the end of every class, and I've kept those. And again, I haven't had any negative feedback. Everybody's very appreciative of it. It gives them a face to put with a name that they know when they call in for additional information. They know who they're calling. But, again, respiratory and radiology and all those folks working with us to hold those morning appointments just for cardiac surgery. They hold those, and we don't release those. They don't release those up until 48 hours prior to the surgery. They will release them to other folks if they need those appointments, but they've been great to work with us, and it has been an effort of each and every department to make those things happen. Advance to the next slide. So the big thing that's come out of this, in addition to the positive feedback, is we have seen this year since inception of this pre-op day, including the class, is our readmissions have decreased. And that, of course, is our overall goal to make sure our patients are safe and that they're seeing the most benefit from this new program. Advance the slide, please. Can I answer any questions?
We actually do have a question in the chat from Becky. Does your night or weekend on-call number send patients to an RN, APP, fellow, or MD?
APP.
And another question she has is your pre-op day different from same day or different? Is your pre-op day different, the same as other surgical consultations? Do they come back again for the pre-op, post pre-op day?
So they have the consultation with the surgeon, and when they go for that consultation, our office administrator gives them a letter with all of these appointments on the letter. So they will actually come back just for the pre-op day. Did that answer your question?
Yeah. Becky, feel free to come off mute if I butchered the question. Okay, she said it's perfect.
Gotcha.
So I just want to add, we really got this idea back before COVID from the joint camp from orthopedic. The patients always seemed so well prepared for their surgeries and did very well after them. And we have had patients say that I finally understand what I'm going through, as opposed to not really knowing what's going to happen. You know, we do education for all of our patients before any surgery, but this does give them a more detailed explanation of what to expect with, you know, day one, the day after day one, day two, and so on. So, it did take us a while, as Cheryl said, but she's done a great job with it, trying to get everything aligned. And it's not always perfect. And also, so patients who come from the cath lab that have to stay and it's close to the day of the surgery, Cheryl certainly invites those families into this class too. So we have found it to be successful and will continue to tweak it and watch it, you know, as we move along with each year.
Any additional questions for this amazing team?
Sherry, this is Judy. And I think you just touched on it, Cindy, but if you have people in-house, so they're washing out their Plavix or, you know, you're waiting for, they had heart failure, you've got to diurese them. Do they get a class too? Or do you send, is Cindy, were you saying you just send the family to one of the other classes?
We usually send the families, and then Cheryl and her team will do education, you know, for the patients separately. So we still do the education. What we do find, of course, is anytime you can do something as an outpatient, the patient is a little more ready to receive the information. Sometimes when you come straight out of the cath, but you got to go for the surgery the next day or two, a little bit of a shock, if you will, is the best way to explain it. And we all have seen that and understand it, and you just try to be as supportive as you can.
Thank you.
Yes, I go to bedside with the education for those families. And I try to do it while the family's there. So they have the extra set of ears that can kind of reiterate some of what I'm saying, because we all know when we get that shock that we walk away and it's like, oh my gosh, what did they say about this? Or what did they say about that?
Yeah,
So you're really busy.
very.
It's a lot of teaching.
Well, that's why we tried to combine it to a class so you don't have to teach, for example, 10 individual patients per week. That's when it gets a little overwhelming, if you will, is the best word to say for it. And we're constantly looking at this and tweaking it. So, and Cheryl's done a great job with the implementation.
Thank you.
Can I ask a question too?
Of course.
Outside of readmissions, from a data perspective, have there been other measures, other avenues that you've seen, even even if it's just just like colloquially, have you seen different effects, I guess, data-wise?
I don't know that we've really tracked anything separate from the readmissions. We certainly know that we've had comments from patients, for example, saying, now I know what to expect. Not my family, but I truly know what to expect. And it makes it, I don't want to say it makes it easy going to open heart surgery because you can't ever really say the word easy for open heart surgery, but it certainly helps with the awareness of this is going to happen on day one, two, three, which we do tend to see patients do better when they know what they're expected to do.
One thing that we have seen a change in is the amount of calls to that
Mhm.
24-hour number post-surgery, because they got the detailed information and they understand a little bit more. I mean, we get the calls about, the pharmacy didn't have my medication or got this little area that I'm worried about. We get those calls. But as far as the calls that usually call back and say, okay, well, how did you tell me I needed to do this? We used to get quite a few of those that have dwindled since we started this process.
Fantastic. Anything, have you seen anything with your HCAHPS or patient satisfaction?
We just do really the individual survey that Cheryl does. I don't know if we've really seen that. Have we, Cheryl? We can look into that though. That's a good idea, Eddie. Thank you.
Cindy, it might be interesting to look at your length of stay. I don't know what the impact of education on, oh, I knew what to expect, so maybe I could get up better or move
Right.
better. It may be the same, but if you're going to look at something, it might be interesting.
Yeah, that's a good idea. Thank you. Thank y'all for having us.
Any other questions for Cheryl and Cindy? Well, thank you so much. Congratulations on the successful patient education program, and we hope you guys continue to see great results, and please keep us in the loop with your updates and progress.
Definitely. Thank you for having
Thank
us.
you.
At this point, are there any other questions, comments, ideas, curiosities, anything folks would like to share with the group tonight?
Eddie, this is Judy. Do you have a sense of when we'll have quarter one STS adult cardiac?
We should have a quarter one STS very soon. Yeah, probably within the next week or so.
Thank you. And then our first biome reports will be in August, do you think?
Yeah, it'll be over the summer. Kind of depends when we get everybody on the platform, but absolutely, we'll be sharing some teasers from Biome, and then the first reports will be out, when the data is available, which I think the harvest is what in August or so.
Oh, that's right. So are they going to take our old data?
Oh yeah, all the old data, all the historical data is going to go over.
Because I think that might be a huge motivator. I think once people can see what they can do and because they're also getting the UBO4
Yep,
data.
that's
Yeah,
correct.
I think seeing that financial, I know you were talking about the financial stuff, like to be able to see that is very interesting.
Yeah, thanks for the questions, Judy. Absolutely, that will all be part of the new reporting platform. And maybe to Dr. Pusios's presentation, we can continue tracking AFib and see how some of that looks in the Biome platform as well. Well, with that, I don't see any other comments in the chat here. I would just sincerely like to thank our presenters this evening, Dr. Puisios, Cheryl, and Cindy. Thank you so much for bringing your great work and sharing that information with our group tonight. Everything that Sherry mentioned with regards to the CME credits will be shared, and you can claim those accordingly. And please do not hesitate to be in touch if you all have any questions or ideas you would like to share as far as improving our patient care for cardiac surgery and cardiology patients across the Commonwealth. Thank you all so much.
Thank you. Have a good evening, everyone.
Thank you.